We will all agree here that seizures and psychogenic seizures pose an important economic, health, and quality of life burden. For people who are undiagnosed, it may take several years before the diagnosis is reached. The bottlenecks for diagnosis is, of course, what the mind does not know, the eyes do not see. That is an ignorant caregiver, an ignorant doctor, an ignorant neurologist, and of course, the fact that we heavily rely on investigations. I will try to convince you all and hope that my luck persists towards the next round of voting, that looking at behavior is sometimes enough for diagnosing psychogenic seizures. I have no disclosures except two, that Itori is my good friend and hopefully will remain so by the end of my talk. And the second is I spoke on the con aspect of this in Athens. So, I could do both. Well, the definition of psychogenic seizures, there are several definitions out there, and I'm just putting up Body's definition. And the first part of the definition itself is that it is an observable, abrupt, paroxysmal change in behavior and consciousness, sometimes also defined as episodes of altered movement, sensation, or experience, and an interictal psychic state. So you could still confuse it with seizures, which are epileptic in origin. And of course, you have to differentiate it from other causes of paroxysmal events. Now, this diagnosis is actually a borderland diagnosis. And as I said, many patients, in fact, at the UCLA study, which was put together by John Stern, there were patients who had gone on for almost 52 years with psychogenic seizures before they were offered the diagnosis of psychogenic seizures. And of course, they require a completely different algorithm of management. Generally, we tend as clinicians to suspect psychogenic seizures and raise the red flags for psychogenic seizures when there are frequent attacks despite careful medical management, and there are atypical clinical features which we'll come through. And of course, when we have obtained a proper history from the caregiver and the eyewitness, and or we have directly observed these events. And then follow on, we go to step 2 and then step 3, and probably video EEG is the last step in the long step of, events. It generally falls into a no man's land, and there, as I said, even to slate the patient for the video EEG, there are limited centers who would, do a prolonged long-term monitoring. There is a referral time, there is a wait list, at least at my center. The wait list for the video EEG is 1 year. So are you going to wait for 1 year before you can even think of psychogenic seizures in your patients? Are you not going to try to cover this earlier? Now, Kurt Lafrance has done the maximum work. Some of, the huge work comes from his authorship. And he put together in Epilepsia 2013 certain cluster of clinical features which we as clinicians could use in our armamentarium for diagnosis. One was, of course, the prolonged duration, the fluctuating course, the waxing and waning nature, stop and go and stop and go. And then asynchronous movements, not following a particular pattern of clonic, just, bizarre left, right, or both lower limbs, one right, one left, so asynchronous movements, pelvic thrusting, side-to-side head movements or body movements, eyes closed, and when you try to open the eyes, there'll be a geotropic movements, or there'll be a Bell's phenomenon if your nurse is doing it, and then crying and shouting during seizures, and then being aware of the seizures. Now, if you look at the sensitivity and specificity, we want to be very specific for the diagnosis. So it's, to the tune of 96 to 100%. And if you look at the phenomenon of postictal confusion and very heavy breathing, again, it goes in favor of the a prolonged post-ictal confusion and post-ictal heavy breathing would go in favor of a true epileptic event. So there was this cluster of symptoms and signs put together based on various publications, which we all have done from time to time. Also the fact that you could make a diagnosis of possible and probable psychogenic seizures and preempt the necessity of a video EEG based on the eyewitness report or the description given by the self and by an astute clinician who has reviewed video recordings. And now we have the home videos, we have mobiles, we have patients coming to us with their mobiles. And the interictal EEG, the interictal routine EEG, done anywhere, a good 40-minute EEG, hopefully including sleep, not demonstrating any epileptiform events. So you could make a diagnosis of possible or probable psychogenic seizures. We at our center have a huge burden of these psychogenic seizures because many of them are drug refractory, and we are a referral center for the drug refractory population. And we too looked at our patients, which was published in 2003. And of course, unresponsiveness during event, hyperventilation during the event, resistance to eye opening, fall, crying, jaw clenching, pelvic thrusting, vocalization and shouting, absence of tongue bite, urinary incontinence, injury and sweating. So these, heavily weighted, these cluster of features heavily weighted towards psychogenic seizures in our population. We also, because we kind of follow these drug refractory patients and try to put them into whether they are surgically controllable or diet controllable or neuromodulation or maybe even psychogenic. So we looked at the role of home videos in making an early diagnosis because our wait list is so huge. And we generally instructed them how to make good quality videos with good light and record at least 3 or more events which were there. And many patients did come back with the home videos. Now, some of them are so typical, one would wonder why one would need a video EEG and ictal EEG recording for these events. And as you can see, the manifestations are all for us to see. Prominent shouting and screaming. Yeah, and so there's one who's just lying there, the first one, and just holding her head. And the events used to arise in sleep, out of sleep for her. So the parents would say, out of sleep, she does this. And she has, it goes on for 15 minutes, the first one. The second one, of course, very bizarre upper limb movements, very bizarre asynchronous lower limb movements. The second one having this, again, bizarre lower limb movements, thrashing around, very prolonged. The boy having waxing and waning too, he tries to even climb up the wall. And of course, the other one was shouting and screaming. So really, if one sees home videos of these events, one would really think whether it is necessary to, even do look at the boy climbing up the wall. And they're very prolonged. They have very typical features, whether it's even required to do a video EEG monitoring to document this when we are so heavily burdened with wanting to document true refractory seizures, which could be amenable for a surgical cure. And this is just to show you how from the rural, impoverished backgrounds of our country, and we are actually two Indias, one is a very poor India and one is a very wealthy India. So just a simple, mobile phone video showing the focal seizures. The eyes are closed, but the seizures are pretty focal and stereotyped in repeated videos which they showed with tonic movements of the left upper limb. So it is possible by home videos to do this. And for this, we had number of videos which came into us. And of the 483 patients, 250, these were patients we screened in our outpatients. 250 of these did not actually have drug-resistant epilepsy, were however told to make home videos, and about 232 had drug-resistant epilepsy and came back to us with home videos. And in the phase 3, we did do the video EEG to, just go back on to how the home videos could predict psychogenic seizures. And this is just the demographics. More were women as expected, and they were young people. They had been having seizures for almost as high as 2 to 5 years. And the features which we found, which were predictive as compared to the gold standard, which was video EG, was eye closure and crying or shouting, breathing difficulty, bizarre movements, and sometimes just lying still with no movements, which had a great deal of accuracy ranging from 96% to 70%. We did conclude by saying that home videos offer a very good utility in preempting a diagnostic algorithm. And of course, they help us pick up psychogenic seizures and can be used as a screening tool. Now to go back to Syed's study, which is published, and where he looked at the caregiver eyewitness account of the things which could happen in psychogenic seizures. Again, it was this clustering versus true seizures, this clustering of features like eye fluttering, awareness, and potentiation or facilitation when a bystander is standing. And so many of them do it in outpatient. When you start taking the history, there's a psychogenic seizure which manifests itself. So these were features which were documented by Syed's study too. This cluster of number of clinical features, and 3 of them stood out: eye flutter, a presence of awareness, and potentiation in front of a relative. Hence, if we use video alone, where video EG is, scarce and few to come by, it should be encouraged, and it can be used as a screening tool for pseudo seizures. Now, we also use various potentiation techniques to document these. Some of them can be used on outpatient basis. A simple thing as putting a vibrating tuning fork on the patient's head, or giving an intravenous saline can provoke psychogenic seizures in as much as with a patch on the neck, it was almost 100%. And of course, elevated serum prolactin levels done within 10 to 30 minutes of the event are higher predictive of true seizures. The key in predicting pseudo seizures with video was the recognition of, the training of the person who's going to pick up these events. And so as the host said, there's a need of education about clinical features, not only to the caregiver, but also to the healthcare providers. Last but not the least, some of our true seizures, ictal events recorded in prolonged video EG monitoring units, a large study done by Reem et al. Published, showed that in as much as about 10% to 5%, you see the white blobs out there, patients with temporal lobe seizures, frontal lobe seizures, and of course with parieto-occipital lobe seizures, you may have a normal EG even during the event. Least to say that the frontal lobe seizures often have movement artifacts during the events. So even ictal recordings may be normal. And my, Ettore here has published this paper, and the title of the paper itself says, "The Semiology of Psychogenic Non-Epileptic Seizures Revisited. Can video alone predict the diagnosis?" Not the video EEG, not the ictal recording. And he himself says there is a degree of accuracy which we can award. Up to a third of patients can receive a diagnosis of psychogenic seizures based on home video clinical history alone. I would like to end by saying that history, caregiver account, and home videos, all of them can be used to our advantage as a good tool for localizing seizures, whether they are true epileptiform or psychogenic. Thank you.